Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Sedatives, Hypnotics and Anxiolytics, a focused review of benzodiazepines and Z-drugs. And our presenter is Dr. Grace Hennessy, Associate Chief of Addiction Psychiatry for New York State OASAS. She'll be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this with other presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and welcome our presenter.
Thank you, Dean, for that welcome, and good day, everyone. As Dean said, we're going to be talking today about benzodiazepine drugs. Before we get into the content, just in terms of disclosures, during this presentation, I will talk about medications, and they are off-label use of medications, which just means that the FDA has not approved the medications for the things that I will be discussing their use for. Our learning objectives today are to describe the basic pharmacology of benzodiazepines and Z-drugs. And when I say Z-drugs, that means specifically zolpidem, which is Ambien, S-zopiclone, which is Lunesta, and Zaloplan, which is Sonata. And we'll hear more about those later. Second learning objective is to gain a better understanding of the risks associated with the use of benzodiazepines and Z-drugs. Describe methods for discontinuing benzodiazepines, including taper schedules, psychotherapy, and adjunctive medications, and gain a better understanding of general guidelines for prescribing benzodiazepines and Z-drugs. So first, a little history. So chlordiazepoxide, which is one of the first benzodiazepines, was synthesized in the 1950s, and it was later marketed in the 1960s as a medication called Librium. And these medications, this medication and the relatives are sedative, hypnotic, and muscle relaxants. Changes to the basic structure of chlordiazepoxide were made, and this increased the potency of the medication between 3 and 10-fold. Diazepam or Valium was created for one such modification. By the early 1970s and by the end of the 1970s, benzodiazepines were being widely used and accounted for 10% of all United States prescriptions. They were being used for the treatment of anxiety and insomnia primarily, and they were a replacement for medications called barbiturates. So before benzodiazepines, barbiturates with medications like Seconal, Tuinal, Nembutal, if those sound familiar, were commonly prescribed for anxiety and insomnia. But the problem with the barbiturates is they had what we call a low therapeutic to toxic ratio, which means that the dose that helped your anxiety and your insomnia was not too far away from the dose that would make you too sedated or actually cause an overdose where you lost consciousness. So people were very concerned about those medications, and there was a search for something better. And that's how benzodiazepines really became popular, because they are less toxic in overdose, and there actually are also few medication interactions, although there are some that we will talk about later. Here is a list of the Food and Drug Administration, or the FDA, approved benzodiazepines, and they're broken down into shorter acting medications and intermediate and longer acting. You may be familiar with some of these names, but some are not commonly used by primary care physicians or psychiatric providers, like midazolam or Versed, which is on the short-acting side. That's actually a medication that's used primarily in anesthesia. But some of the ones you may be familiar with, like Xanax, Klonopin, Valium, and Ativan, those are ones that people tend to commonly know, and those are the more commonly prescribed medications in the general population. This graphic demonstrates how benzodiazepines work. So this is a picture of a brain cell. So this is one of your neurons. So this is the outside where it says ethanol binding site and barbiturate binding site. That's the outside. Also where it says outside, I should say, is the outside of the nerve cell. And the inside is the inside. And this is a receptor. So this is what we call the GABA receptor. This whole thing is the GABA receptor. GABA is an important neurochemical that we all have that binds to this receptor, but other things also bind to this receptor like alcohol, barbiturates, as I mentioned, and benzodiazepines. So when any of these chemicals, so GABA, ethanol, barbiturates, or benzodiazepines bind to this receptor, they open it up. And this hole opens up and chloride ions go through from the outside to the inside. And chloride ions basically calm things down. So they are negative ions. You see the negative sign. And those just tell the neuron, the brain cell, to just kind of chill out, just calm down. You don't need to be so excited, no need to fire so quickly. And that I think it makes sense when we think about what benzodiazepines do, in that they help people sleep and they help with their anxiety. The challenge with the barbiturates, just to go back to why they were taken off the market and what made them dangerous, is that they just kept the channel open. So the channel was constantly open, and you got this constant flow of the negative ions in, and it would really depress the neurons so much that breathing would stop and people would overdose. Where the benzodiazepines are different is they regulate the rate of opening and closing. So the channel still opens and closes, it's just the rate of it is slowed down so that more negative ions can get in. But again, it is safer because it's not just open all the time. The Food and Drug Administration has approved benzodiazepines for generalized anxiety disorder, or GAD, insomnia, panic disorder, seizures, and social phobia. There are other conditions for which they are frequently used. One of them in the work that we do is for the management of alcohol and benzodiazepine withdrawal in hospitals or in detox settings. There are adjuncts to anesthesia prior to surgery. As I mentioned earlier, midazolam is something that's used in surgery. Muscle relaxants in pain management, and in acute agitation management in combination in antipsychotics, usually in an emergency room setting or in a psychiatric hospital setting. They do remain one of the most prescribed medication classes in the United States, and an estimated 92 million prescriptions for benzodiazepines were filled in the United States in 2019. Xanax, Klonopin, and Ativan comprise 82% of all the prescribed benzodiazepines in the US, and you can see the breakdown that Xanax is the most commonly prescribed at 38%, Klonopin is second at 24%, and Ativan, lorazepam at 20%. The thing about benzodiazepines is really the recommendation for their use is only about 4 to 6 weeks. So these are not medications that are meant to be used long-term, but they actually end up being used long-term. Many individuals remain on benzodiazepines for years, and studies have shown that longer-term use is associated with being older, being female, and having high levels of psychological distress, particularly depression and anxiety. And the reason why I highlighted older is because benzodiazepines continue to be widely prescribed among older adults for insomnia and anxiety in particular, but there are concerns about how these medications do affect older adults. The American Geriatric Society in 2019 published the updated Beers criteria for potentially inappropriate medication use, or PIM, in older adults. The American Geriatric Association has been publishing these Beers criteria since 2012, and they update them about every 3 years or so. And when I was first putting together this talk, I looked up a lot of studies that talked about the effects of benzodiazepines in older adults. But then I came across this information, and I found it really succinctly stated what I was trying to convey with the multiple studies I was going to fill up this talk with. And what the American Geriatric Society says is older adults have increased sensitivity to benzodiazepines and decreased metabolism of long-acting agents. In general, all benzodiazepines increase risk of cognitive impairment, delirium, falls, fractures, and motor vehicle crashes in older adults. And their recommendation is that benzodiazepines should be avoided, or to avoid them in prescribing practices for older adults. And the strength of this recommendation is considered strong. So what the American Geriatric Society did is they looked at all the studies kind of like I did, although they looked at way more than I did and more in depth. And they really found the evidence said that falls, delirium, cognitive impairments, so memory problems, fractures, motor vehicle crashes were found to be a significant issue in older adults who were taking benzodiazepines. So it is not, they are not recommended for older adults, even though they are prescribed commonly for them. In addition to these concerns about the effects on older adults, misuse potential is a concern for individuals of all ages. So that being said, the misuse potential has actually been described as quote unquote intermediate. So opioids and stimulants have been considered to have a higher misuse potential. So benzodiazepines would be less than opioids and stimulants, but still an issue that they can be misused. And the misuse potential of the benzodiazepines varies by the medication. The pharmacologic differences in the medications play a significant role, and certain issues such as speed of onset of the effects after administration, such as the relief of anxiety or dysphoria, the sense of well-being and euphoria affect whether or not people misuse them. So the quicker you feel better, you feel your anxiety's improved, your sense of well-being, your euphoria comes on, that makes it more attractive to people to continue using them or misuse them. And certain medications like alprazolam, diazepam, and clonazepam, so again, Xanax, Valium, and Klonopin respectively, have a relatively rapid onset. So people do tend to like those benzodiazepines better. Oxazepam, which is called Cirax, has a very slow onset. So you don't often hear people misusing Cirax. It's probably incredibly rare, and it's not really seen in the literature, but it comes on very slowly, so people don't get their anxiety relieved or feel euphoric quickly, so it makes it less attractive as a medication. When individuals overuse or misuse benzodiazepines, intoxication will occur. Symptoms of intoxication include slurred speech, incoordination, unsteady gait, nystagmus, which is when you get kind of this funny beating in your eye movements when you move them from one side to the other, impairments in cognition, again, particularly attention and memory, sedation, decreased reflexes, stupor or coma. In more extreme examples of overuse of benzodiazepines, and they can lead to respiratory depression and death in more severe cases. For older adults, their increased sensitivity and decreased metabolism of the benzodiazepines makes them more prone to these symptoms of intoxication, and in turn can result in the problems that we previously mentioned, falls, fractures, and so on. So that's why they're such a concern. Withdrawal is also a concern with the use of benzodiazepines for individuals of all ages, and the pharmacologic differences in medications we discussed earlier are also important in withdrawal symptoms. Withdrawal symptoms include autonomic hyperactivity, which is sweating, a pulse greater than 100 beats per minute, an elevated temperature, hand tremor, insomnia, nausea or vomiting, transient or short-lasting visual, tactile, or auditory hallucinations, psychomotor agitations, having trouble sitting still, feeling very restless, anxiety, and in the worst case scenario of benzodiazepine withdrawal, if it goes on for a long time and it's not treated, people can have seizures. Taking benzodiazepines daily at prescribed doses, so if your doctor says take it at this dose regularly and you do what they say for a month or more, can lead to withdrawal symptoms. Again, if you're taking your medication appropriately, you're not misusing it, the severity of the withdrawal symptoms may not be as great. So sort of moving down this list of symptoms, you may not get things like hallucinations, definitely not get seizures, but you may feel some of the symptoms that are listed at the top. So that sweating, feeling shaky, having trouble sleeping. Pharmacologic differences also play a role in withdrawal symptoms. So the persistence of active medication or its metabolite or its breakdown product in the body is something that's called the elimination half-life. And this is a significant factor in how quickly the onset of withdrawal symptoms will be experienced. So if a medication has a shorter elimination half-life, so if it leaves your system quickly, you will experience between dose withdrawal symptoms. So if you're taking a short-acting benzodiazepine, you're taking it a couple of times a day, you're taking it 3 times a day, and you miss that middle dose, you might start to feel some of those withdrawal symptoms as it gets close to the time to take the 3rd dose. And also the withdrawal symptoms come on earlier and they're more pronounced. And the 2 medications that are most significantly associated with the shorter elimination half-life and this experience of having the withdrawal come on quite quickly are alprazolam or Xanax and lorazepam, which is also called Ativan. Medications that have a longer elimination half-life decreases the likelihood of between dose or earlier more pronounced withdrawal symptoms or syndromes. You'll still get them when you decrease or stop the medications, but they may not be as severe because, again, that elimination half-life, the amount of time that medication stays in your system, is much longer. So examples of the longer elimination half-life medications include chlordiazepoxide, clonazepam, and diazepam, and those are Librium, Klonopin, and Valium, respectively. And this is why these medications are often used as treatments for alcohol and sedative, hypnotic, and anxiolytic withdrawal because, again, they stick around a long time. And as we saw earlier when we showed you the neuron with that binding site, you saw that alcohol binds onto that same place on the receptor, not the same place, but binds to that receptor like the benzodiazepines do. So that's kind of why we use these medications. You're sort of trading out one medication that works one way, or one substance, excuse me, alcohol, for a medication that acts similarly, which are the benzodiazepines. And that's why we use them to treat withdrawal. This table just highlights what we discussed. So there's a list of some of the different medications on the left-hand side. There's the dosage and their equivalents. So as you know, medications don't all come in the same size. So 0.5 milligrams of Xanax is about the same as 10 to 25 milligrams of Librium, which is about the same as 5 milligrams of Valium or a milligram of Ativan. So that's sort of their rough equivalencies. And you can see how quickly some of them come on, which we mentioned earlier. So we said Xanax and lorazepam were ones that people may be more likely to misuse because you feel the effects very quickly. But the challenge with them, again, in terms of withdrawal, is they leave your system very quickly. Their duration of action is only 3 to 4 hours, and they only stay in your system, in the case of Xanax, for about 11 to 16 hours. In the case of lorazepam, again, 4 to 6 hours, but they only stays around 10 to 20 hours. So again, they don't stick around a long time, so you get those withdrawal symptoms. As we talked about, then you have medications like Librium, chlordiazepoxide. Look how long that stays in your system, right? So 5 to 20 hours, because Librium has a lot of active breakdown products or metabolites, so it sticks around for a long time. Same thing with Valium, that'll stick around for over 100 hours. So again, Klonopin sort of in between, about 20 to 80 hours. So those medications will stay in your system longer, again, so they're good for use in detox, and you don't get the withdrawal phenomenon coming on as quickly and as strongly as you do with the shorter acting medications. This is kind of a busy slide that shows you just how the medications are broken down. So as I mentioned before, Librium or chlordiazepoxide is on top. And we said that had a lot of active metabolites. You can see it breaks down into other chemicals in your system. And all of these are active. So they do things similar to the parent compound, the chlordiazepoxide, just they're not as strong, but they still do something. So as all these accumulate, it works well to help keep withdrawal at bay. And then they're all broken down to oxazepam. And this just shows some of the other benzodiazepines. Metazepam is not available in America, but I couldn't find a good slide like this one that had the medications that didn't mention that one. So you can see there's Valium and the breakdown products, and these are why, again, these are stick around longer in your system. You can see down in the left-hand corner, alprazolam or Xanax really just has one metabolite that is kind of active. So that's why it disappears so quickly. It doesn't stick around. Klonopin does have one metabolite as well, but again, this one sticks around a little longer. But again, this is part of the challenge with some of these medications. So because of the concerns about misuse of benzodiazepines, the FDA added a boxed warning to benzodiazepines in September of 2020. And a boxed warning is just a box and with print in it that is in the physician's desk reference, the PDR, that is a specific and highlighted warning about a particular medication. So if you looked up Klonopin or Ativan or Xanax in the physician's desk reference, which you can look up online, you would see on the first page this highlighted box. And in it, you would read, the use of benzodiazepines exposes users to the risks of abuse, misuse, and addiction, which can lead to overdose or death. Before prescribing and throughout treatment, assess each patient's risk of abuse, misuse, and addiction. Abrupt discontinuation or rapid dosage reduction after continued use may precipitate acute withdrawal reactions, which can be life-threatening. To reduce the risk of withdrawal reactions, use a gradual taper to discontinue or reduce the dosage. So the FDA really wanted to make the point that, yes, these medications have their use, but you really need to be cautious with them because of misuse and because of the seriousness of abrupt withdrawal. This boxed warning actually added another boxed warning that had been placed back in 2016 about use of benzodiazepines with opioids. And this boxed warning said concomitant or co-occurring use of benzodiazepines and opiates may result in profound sedation, respiratory depression, coma, and death. Reserve concomitant prescribing for use in patients for whom alternative treatment options are inadequate. Limited dosages of benzodiazepines and durations to the minimum required, and follow patients for signs and symptoms of respiratory depression and sedation. And this was added because we know and we've learned over time that opioids, so prescribed opioids, but also heroin, fentanyl, depress the central nervous system respiratory drive. So when you use opiates, your drive to breathe, if you use too much of them, goes down. Benzodiazepines also drive down your respiratory drive, so to speak. So you may breathe less frequently, and when you put the two together, the situation is worse. So you get this additive effect where the respiratory drive is depressed by opioids, and then benzodiazepines come in and they also depress the respiratory drive, and that can lead to overdose and death, as we previously mentioned. In a 2000 study by Torrey and colleagues of over 400,000 opioid overdose deaths between 1999 and 2017, they found that benzodiazepines were co-involved in many of these opioid overdose deaths. And they found that it changed over time. So it was a little under 9%, so 8.7% in 1999. It rose to 26% in 2010, which was the peak. And around that time, that's really the peak also of the opioid crisis in terms of the prescription opioids. So that's where you really see, well, that's probably the peak of time when there were many, many people getting prescribed prescription opioids, and they were also getting benzodiazepines. So those two things together contributed to it. It did drop in 2017 to 21%, but after the rise of the opioid epidemic and the opioid prescription epidemic, when those numbers started to drop, when the prescriptions went down, people moved to using heroin, and unfortunately also fentanyl was in the supply. So even though it went down, people were still using opioids at high levels. They just shifted from prescription opioids to street opioids, so to speak, heroin and fentanyl, so you see this decrease. But the benzodiazepine prescriptions were still being given to a lot of people, even though they were using opioids that they were obtaining on the street. The co-involvement was greatest with the prescribed opioids, as I mentioned, and there was a co-prescribing quadrupled between 2003 and 2015. And this was actually mainly seen in primary care settings. So a lot of opioids and benzodiazepines were being prescribed by primary care docs. And they found in this study there was a positive correlation between the number of opioid overdose deaths that involved benzodiazepines with the state benzodiazepine prescribing rates. So if they looked at New York, let's say, and 30% of doctors in New York were prescribing benzodiazepines, but in Kentucky it was only 20%, there was a sort of corresponding increase. So there would have been more overdose deaths than with opioids and benzodiazepines in New York than compared to Kentucky. So now that I've convinced you that prescribing benzodiazepines may not be the best treatment option for patients, the next question is, how do you taper patients who are already taking these medications off of them? It's not easy. So tapering and discontinuing benzodiazepines is an individualized and slow process. It's complicated by the benzodiazepine withdrawal symptoms, a return or a worsening or an exacerbation of pre-treatment anxiety levels. Patients are reluctant and they often refuse to go off of them because they work and their symptoms are well treated, so why stop it? And patients get very distressed during the taper. So I've tapered a number of people in my time off of benzodiazepines, and it's very stressful for them because many times they've been taking the medications for many years and they work, but for reasons, medical reasons, it's a good idea that they come off of them, and it's just very difficult to do it. Factors associated with taper and post-taper outcomes include the duration of benzodiazepine use. So the longer you've used or taken the benzodiazepine, the harder it can be to come off of it. The type of the benzodiazepine used, so those shorter acting ones that we mentioned earlier, like Xanax and Ativan, can be harder to come off because, as we talked about, you get the withdrawal symptoms more quickly and more intensely. If you have co-occurring psychiatric conditions, so if you have an anxiety disorder that's being treated by the benzodiazepines, that can make it challenging to come off. Other substance use, if you're using alcohol, opioids, and how quickly you reduce the benzodiazepine dose over time. Guidance on discontinuing the medications really varies. There's evidence-based recommendations that's in the medical literature, but there's a lot of non-evidence-based material from numerous blogs, websites, published and non-published resources that are available to the public. It's important for those of you listening to this who are prescribers to ask patients what they know about tapering and discontinuing benzodiazepines before you make the plan of how you're going to take them off. Some people's knowledge may range from the scientifically based to actually the very dangerous from what they may read online. Withdrawal symptoms may be confused with a return of symptoms, particularly anxiety. So it's very important to provide education about what patients may experience during the taper. So as we mentioned a bunch of slides back, anxiety is a withdrawal symptom that people will experience. Again, what we're going to talk about is gradual tapers, but still the anxiety happens. It's unfortunately something that's difficult to avoid. And you should check in regularly to monitor symptoms and provide support to people as they are tapering off benzodiazepines. When you read the literature, the proposed tapering schedules are variable. They include a 25% weekly dose reduction schedule. That's the one most frequently investigated and studied. And usually what happens first is you switch from a shorter acting to a longer acting benzodiazepine. So if someone's taking Xanax and they're taking it a couple of times a day, you want to figure out what that would be equivalent to, say, Klonopin or Valium or Librium, and switch them over first, and then do the 25% weekly reduction of the dose of the Librium or the Valium or the clonazepam rather than the Xanax, which would be much harder to do. The 25% weekly dose reduction schedule had better outcomes than an alternative weekly dose reduction in studies where they looked at this, and because the proportion of patients who successfully discontinued the benzodiazepine use when they did the 25% weekly dose reduction with the switch to a longer acting benzodiazepine was higher than in other ways. Some other studies have done symptom-guided withdrawal that has also demonstrated some efficacy. There was only one small study of 50 patients, and what they did in these studies is they would say, okay, so we're going to cut down your, let's go with your Librium dose, you're at 100 milligrams, we're gonna cut it down by 10 milligrams to 90 milligrams. And we're gonna check in with you in a week and see how you're doing. So if in a week, that person was still having a lot of anxiety, wasn't sleeping well, they would hold and say, okay, we're not gonna do another reduction, we're gonna wait until your symptoms have resolved, your anxiety is lessened from this decrease, and then we will go from there. Again, this is not widely studied. There was one small study in the literature of about 50 patients. But in this study, 70% who did the symptom-guided withdrawal, so where they had a lot of control and say in how they got off the benzodiazepines, actually remained off the medications for up to 3 years after these studies. Another strategy is tapering by 1/8 to 1/10 of the daily dose every 2 weeks. And some researchers recommend this is over 6 to 8 weeks that you do this taper, but others caution it may take a year or more to complete a taper. And that's usually when people are on higher doses of benzodiazepines and taking them for a long time. But the important thing to remember is that steady state for medication takes 5 to 6 half-lives. So what does that mean? So if you mentioned, as we mentioned earlier, a couple of slides back, we talked about the elimination half-life. So how long does it take to get a certain amount of the medication, usually half, out of your system? Well, it also works in reverse in that it takes a while when you start taking a medication to build up on those half-lives. So you have to take a medication for several days or sometimes longer before you get to a point where the level in your blood is steady, or what we call a steady state. So when you're switching from a shorter acting to a longer acting medication, you have to be careful that you don't abruptly stop the shorter acting one while the other one is reaching a steady state in the blood level, because people will have abrupt withdrawal, they won't feel comfortable, and it won't go well. So there'll be a period where someone is taking, say, their shorter acting benzodiazepine like alprazolam and a longer acting one like chlordiazepoxide. So this table just shows how you can look at the equivalency in doses and look at the half-life as you're thinking about how you're going to switch. This table is actually from an article by C. Heather Ashton, who is a pharmacologist, physician, and professor at Newcastle University in England. She actually ran a successful benzodiazepine discontinuation clinic for over a decade. And this conversion table has been widely cited in textbooks and other literature and has been used by many clinicians around the world. So, you know, for example, if you were going to switch someone, say, to Librium to do their taper from alprazolam, so if they were taking 0.5 milligram a day, you would start them on 25 milligrams of Librium a day or chlordiazepoxide, and then you'd want to wait these 5 or 6 half-lives, right? So we said 5 or 6 half-lives. So at the earliest, you would want to start tapering the alprazolam, say 25 to 30 hours after you started the chlordiazepoxide. So you'd want to give it a couple of days. Again, it can be up to 30 hours, but you'd give it a couple of days before you'd cut down on the Xanax dose. And then when you cut down on the Xanax dose, then you can start working on cutting down the chlordiazepoxide dose. So before we discuss medications that have been used as add-on treatments for tapering and discontinuing benzodiazepines, I want to review that while there are no medications approved by the FDA as adjunctive or add-on treatments for benzodiazepine tapers, several medication classes have been the subject of clinical trials. Few medications, however, have demonstrated efficacy for facilitating successful discontinuation and relief of benzodiazepine withdrawal symptoms. When medications are prescribed off-label, providers should document carefully that they educated the patient about risks, benefits, alternatives, the evidence for using the medications, and the fact that the medications have not been FDA approved to treat the indication for which they are prescribing them. Providers should assess patients regularly and carefully during benzodiazepine tapers for treatment progress, adverse effects, worsening of psychiatric or medical symptoms, and high-risk behavior, such as self-harm, suicidal ideation, high-risk substance use, and violence risk, particularly when off-label medications are prescribed. These areas should be assessed and documented in the medical record each time they are assessed. Off-label medication should be provided along with as robust a psychosocial treatment plan as patients are able and willing to engage in. Medication should be discontinued if patients are experiencing no clear benefit after a reasonably adequate trial. So what medications do help people? So if you're taking someone off benzodiazepines, are there medications that people can take with them that might make this situation easier for them? So in 2018, there was a review by Justine Welsh, who's at Emory University, and her colleagues, where they looked at a whole bunch of studies that had adjunctive pharmacologic approaches for these tapers. What they found was the studies were very limited. So the sample selection had a lot of heterogeneity, which just means there were different types of patients with different types of comorbid disorders in the group. So some people had other substance use disorders. Some studies, other people had psychiatric disorders. Some had been taking benzodiazepines for short periods of time or long periods of time. Some had tried to get off the medication before, some hadn't, and the patient age. So there wasn't really sort of a uniform, nice way of looking at all the people who had been in these studies. They were very variable, which makes it hard to draw conclusions that we can use for everybody. The sample sizes were small, so some of these studies there might have been 8 or 10 people, which is hard to draw conclusions from about the efficacy. And there was a lot of inconsistency in measuring withdrawal symptoms. So some studies, they looked at subjective symptoms, so they might have had a clinical instrument where they checked off symptoms, but other ones were just like asked questions and the physicians kind of came up with their own way of assessing things. So again, it makes it very difficult to give general thoughts about what medications might work. And some of the studies, they didn't really talk about the taper protocols. They just said we tapered them off the medication. We tapered them off the benzodiazepines while they were on this other medication. But many studies did report it. And the ones that did, they did use that 25% per week reduction that I had mentioned earlier over about 4 to 6 weeks. Most of the time, they did switch them over to diazepam or Valium or chlordiazepoxide, Librium equivalents like we talked about. So again, switching from the shorter acting to the longer acting to hopefully make the situation easier. What they found was melatonin, which is something you can buy in the GNC in the local stores. You can buy it in local drugstores. You can also get it by prescription. Had mixed results in 2 randomized placebo-controlled trials. One small study found promising results for sleep. So people slept better and they actually had an easier time during the taper and coming off the medication. So that was very exciting. So then they did a larger study, about a moderate sized study of patients with schizophrenia, schizoaffective disorder, and bipolar. But they did not find as much benefit with melatonin when they coupled it with a 10 to 20% biweekly benzodiazepine dose reduction. So every 2 weeks, they went down 10 to 20%. They gave people melatonin. And actually, they found in this study, unfortunately, that the cessation rates were actually better in the placebo group. So the group that got the non-medication did much better at coming off the benzodiazepines than the group that got melatonin. 48% tapered off successfully during the study versus 38% who got melatonin. It certainly can be considered as an agent for insomnia during the taper. That's what Welsh and colleagues recommended. It is safe and it is widely available, so it's something that can be considered if people are having trouble sleeping during a taper. 2 studies of trazodone. Trazodone is a medication physicians prescribe very, very commonly for sleep, but really there was no improvements in taper completion or reduction in withdrawal severity when they used that. And again, interestingly, they didn't really look at sleep, but it was just felt that trazodone was not very helpful. In terms of other studies, buspirone, which is a medication that is an anxiolytic that gets used as an add-on medication, really didn't help with anything with cessation or withdrawal symptom relief. Paroxetine or Paxil, which is an antidepressant, did do okay in patients with major depression who were also coming off a benzodiazepine. It was actually good for treating the depressive symptoms and it could improve taper completion rates, but it wasn't really a lot better than the placebo or the control part for the completion rates. But the group that was on Paxil also reported fewer symptoms of depression and anxiety. So there may be some use there for Paxil for people with depression or anxiety as they're coming off benzodiazepines. in a smaller study that did not include people with major depression, found that the paroxetine group was more likely to be off benzodiazepines at 8 weeks compared to the taper-only group. And what Welsh and colleagues concluded is that you can consider Paxil, paroxetine, for individuals with co-occurring depression or anxiety who are coming off of benzodiazepines. Carbamazepine or Tegretol, which is an anticonvulsant, was studied against placebo, and it was found, they did find significant between group differences in reducing withdrawal symptoms in favor of carbamazepine. So that means it was better than the control condition. Carbamazepine is a tough medication, however. There's a lot of side effects that go along with it. There is a risk of what we call agranulocytosis, which is a fancy word for really destruction of all your white blood cells. And we know our white blood cells are very important in our immune response. So it is a risk. It is a very small risk, but it is something that is there. It also interacts with a lot of other medications. So you can get increased levels of some medications or decreased levels of other medications when you're taking Tegretol. And you also have to monitor blood levels. So people who take carbamazepine, also known as Tegretol, have to have their blood levels checked, and you have to monitor those white blood cells to make sure that those numbers are not going down in a dangerous way. There was no study of gabapentin or Neurontin as an adjunctive medication. There was one very small study of 19 people looking at gabapentin versus placebo for benzodiazepine use disorder in individuals treated with methadone for opioid use disorder. So as we talked about before, an important group that we want to think about making sure they're not taking benzodiazepines because of the risks of benzodiazepines with methadone and other opioids. But they really found that there was no difference in those who got gabapentin or those who did not. But the other problem is half the patients dropped out. They didn't want to be in the study. They didn't complete the study. So it wasn't the world's best study, but it was something to think about because a lot of people are interested in gabapentin for treatment of anxiety, alcohol withdrawal, and benzodiazepine withdrawal. So moving on from medications, there's also been psychotherapeutic approaches to managing benzodiazepine withdrawal. So in 2016, there was a Cochrane review, Cochrane is an organization where they have researchers and other clinicians review many studies. And then they publish these reviews where they synthesize all the information that they got from reviewing the studies. So in 2016, the review came out about using psychotherapies for benzodiazepine tapers. And what they found was cognitive behavioral therapy, or CBT, plus a benzodiazepine taper only, without the CBT, led to more successful discontinuation of the benzodiazepines at 4 weeks into the study and at 3 months. So in the short term, CBT added to the taper seemed to help, although the effects were less certain in these studies at 6 months, 11 months, 15 months, and 24 months. But again, some good early outcomes, so something worth considering. Reductions in benzodiazepine use were also seen in this review with relaxation techniques, so teaching people deep breathing or progressive relaxation exercises when they feel anxious coming off their benzodiazepines. And interestingly, a letter from a general practitioner with information about benzodiazepines and encouraging people to reduce their use actually had some positive benefits. So people got a letter from their doctor saying, try reducing fill in the blank benzodiazepine by 1/2 tablet every few weeks. Interesting. Motivational interviewing, where you try to talk to people, you try to assess people's willingness to make change in terms of their substance use and motivate them to make that change, was actually not found to be effective with benzodiazepine tapers. So now we're going to switch gears for the last part of this talk, and we're going to talk about sedatives, hypnotics, and anxiolytics with a focus on the Z drugs. So the Z drugs are FDA-approved non-benzodiazepine medications to treat insomnia. The main ones are Zolpidem or Ambien, which most people probably have heard of. It also comes in a sustained release or a controlled release formulation, Ambien CR. It comes in a version called Intermezzo, which is formulated for middle insomnia, which is when you wake up in the middle of the night, you're wide awake and you can't get back to sleep. There's Edluar, which is a sublingual version of zolpidem, so you put it under your tongue with the idea that you get the effects of it much more quickly, and Zolpamist, which is a mist, it's a spray. It's a spray version of zolpidem. There's esazopiclone, which is called Lunesta, and Zaloplan, which is called Sonata. These medications were introduced in the 1990s for the short-term treatment of insomnia. And once again, the recommendation for these use, same as benzodiazepines, is about 4 to 5 weeks, 6 weeks at the most. And what the difference was with these medications compared to the benzodiazepines is that they bound to that same receptor, but they bound in a different spot. They bound on the alpha-1 subunit of that receptor I showed you before. I'm going to show it again. And what they found was by targeting it to a particular spot, you got more sedation and amnesia, so people slept better. And it made it a more potent sedative medication with minimal effects on anxiety. So the Z drugs were not felt to be good for anxiety because, again, they focused on that sleep part of the receptor. And in studies, they found that the Z drugs reduce sleep latency, so people fell asleep more quickly, and they improved sleep quality, so people felt like they got a better night's sleep. It wasn't really clear if their actual time asleep was prolonged, but again, people fell asleep more quickly and they felt like their sleep was good. So even if they didn't sleep as many hours as they may want to have slept, they felt okay. So it wasn't really critical that the total sleep time was prolonged. So I'm just going to show you this graphic again. So again, the outside and the inside. Unfortunately, I could not find a picture that showed where the Z drugs bind, but they do bind on this alpha subunit, the one that's facing us. They bind onto there. So again, it's very targeted, it's very specific there. And that's how they exert their action. And like the benzodiazepines, they open up the pore. But again, they open it up. They control the rate of opening and closing, like the benzodiazepines. So they're not as dangerous as the medications like the barbiturates. So it's really felt that these medications, all the Z drugs, had advantages over the benzodiazepines and other medications that helped you sleep. They had a rapid onset of action, so the time to maximal concentration, so the time that you get the most effect from them is about 1 to 1.5 hours after you take them. They are rapidly metabolized, so they're out of your system pretty quickly, and they don't have active metabolites. Like, remember I showed you that graph with all the arrows, and this medication breaks down into this medication. You don't have it with this, so they don't stick around in your system very long, and their half-life ranges from about 2.5 to 6 hours. If you remember when we talked about chlordiazepoxide or Librium, that range was like 30 to 200 hours. So this is a much, much shorter time frame. And the other advantage was that they didn't alter sleep architecture. So what that means is that it didn't mess with those deep levels of sleep that we all get each night. So the deep sleep phases did not become affected, because actually the benzodiazepines do affect those deep sleep phases. You actually get reduced deep sleep phases with benzodiazepines. Those phases are sort of considered our best sleep, our restorative sleep. And the Z drugs didn't seem to do that. So that was a good thing. Now, the Z drugs were also thought, and I stress thought, not to cause residual daytime sedation, so people didn't feel sleepy in the morning, impairment in cognition and motor functioning. People did not develop tolerance where they needed more and more higher doses to get the same sleep effect, and that people didn't experience withdrawal. So just to show you a little table with all the Z drugs, just to show you again the list of them, the usual doses, the onset of action, how long they last, and what they are good for. So again, all comes on very quickly, between 20 to 30 minutes. The half-lives range from 0.5 hours, so 30 minutes, up to the most of being 5.5 for the controlled release Ambien, and what they're good for. So just a little table so you can see the differences between them. So the problem was the Z drugs did have adverse events. So all those things that we thought didn't happen, weren't going to happen, actually did. People complained of residual daytime sedation. People felt sleepy the next day after they took them. And the other concerns was there were impairments in the next day's their next day psychomotor performance. People didn't feel as alert. People felt their memory was affected. Some people complained of balance problems. Their reaction time was slowed, and people felt like their ability to multitask was reduced. And what they found was, when they looked at in the studies, when the people complained of this, is that they weren't taking them and then getting a good 7 to 8 hours of sleep time. So it's really felt like when you take these medications, any of the Z drugs, you should take them when you have 7 to 8 hours to actually sleep. Because during that time, the medication will wear off. We saw that they have very short half-lives. But if you take it at 4 in the morning and you have to get up at 7 in the morning, you're going to feel these types of things. They also found that what they didn't find in the studies is that some people had problems like hallucinations at typical doses. So people hallucinated in very, very rare cases. People had psychosis where they were hearing things as well, lost touch with reality. Those were incredibly rare, but these were concerns that came up over time. And people did become tolerant to the effects, so they needed higher doses, or they were taking more pills to get that sleep effect. And people did have dependence on them. And the dependence was shown by withdrawal symptoms. So when people stopped the Z drugs abruptly, they did have these withdrawal symptoms, all exactly the same as the ones we talked about with benzodiazepines. So the autonomic hyperactivity, sweating, elevated pulse, elevated temperature, hand tremors, insomnia, nausea, vomiting, hallucinations, psychomotor agitation, and anxiety. Very rare for people to have seizures, so grand mal seizures, so full body seizures when they stop the Z drugs, but they were reported, again, incredibly rare, more likely when you are taking benzodiazepines at high doses for a long time and you stop them than with the Z drugs, but it was something that was there. A particular concern that developed over time was driving. So they did studies of zolpidem, so Ambien in particular, and driving. And they found that people had significant impairment in driving with blood concentrations of Ambien above 50 nanograms per milliliter. And they did studies, and they found that 8 hours after taking the immediate release zolpidem or Ambien, 15% of women who were studied and 3% of men met this level. So again, they took it 8 hours before with the recommended time. It should have been out of their system, but it wasn't really out of their system, and then they had trouble driving. And what they concluded from these studies is that women metabolize Ambien or zolpidem more slowly, and they found older adults do as well. So the recommendation was that people should not take any more than 10 milligrams of Ambien for men and 5 milligrams for women and older adults. The other problem that came up was complex sleep behaviors, or CSBs. And since 1992, the FDA has identified 66 serious cases of complex sleep behaviors related to Z drugs. These included sleepwalking, sleep driving, and sleep cooking. Accidentally overdosing on medications. People fell. Some people accidentally burned themselves. There was one case of someone shooting themselves after taking the medication. And people wandered outside in cold weather, and there were 20 deaths as a result of complex sleep behaviors. Now, I want to stress these medications are widely prescribed. Not as much as the benzodiazepines, but if you remember, there were 92 million prescriptions with benzodiazepines. Z drugs are not quite at that level, but they are widely prescribed. So these events are incredibly rare, but they're obviously of concern. So in 2019, the FDA added one of those boxed warnings to all the Z drugs about complex sleep behaviors. Complex sleep behaviors, including sleepwalking, sleep driving, and engaging in other activities while not fully awake, may occur with the use of, and fill in the name of the Z drugs, zolpidem, S-zolpicam, etc. Some of these events may lead to serious injuries, including death. Discontinue the medication immediately if a patient experiences a complex sleep behavior. And they added a contraindication, is that whichever Z drug the person is taking is contraindicated, meaning it should not be prescribed again to patients who have experienced complex sleep behaviors after taking the medication. So this situation doesn't get better if you stop the medication and put them back on it. And so if someone does have complex sleep behaviors, even if it's simple, they get up, they walk out, maybe they take a drink of water, but they don't remember it, you should not take the medication. It should not be prescribed again. Going back to older adults, so the American Geriatric Society has also expressed a concern about Z drugs in older adults. And in their 2019 updated Beers criteria for PIMS in older adults, They did say that benzodiazepine receptor agonists, hypnotics, so the Z drugs, have adverse events similar to those of benzodiazepines in older adults, so delirium, falls, fractures, increased emergency room visits, hospitalizations, motor vehicle crashes, and there's minimal improvement in sleep latency and duration in older adults in studies that they've done. And the recommendation was to avoid using them in older adults. And the strength of the recommendation was strong. There's also a concern about the increased risk of unintentional overdose for those taking opioids with Z drugs. So Z drug respiratory depression has been reported, similar to the benzodiazepines. And in 2012, a study of approximately 511,000 patients co-prescribed opioids and Z drugs matched to patients prescribed only opioids. So this was looking at insurance data, opioids only between 2014 and 2017 found there were about 53 overdose events per 10,000 patients years for the co-prescribed group, so people who were getting Z drugs and opioids, whereas there were only about 14 overdose events per 10,000 patient years for the opioid only group. So when they did the math, they came up with what they call an adjusted hazard ratio of 2.3 after controlling for other confounding factors. So that meant if you were prescribed an opioid and a Z drug, you were 2.3 times more likely to experience an overdose event than people who were just prescribed opioids. So a significant issue. Again, not everyone who takes opioids and Z drugs are going to have this happen, but the risk of this happening goes up. Interestingly, even though this was found, and this has been a concern for other researchers, there is no boxed warning for opioids or Z drugs about the risks of the other. So opioids don't say anything about Z drugs don't say anything about opioids, and it just talks about CNS depression risk only. So some considerations when prescribing benzodiazepines and Z drugs, please really should be avoided whenever possible. Use other things. Use with caution if you are prescribing with opioids and or other medications that depress the central nervous system. Try psychotherapeutic and behavioral interventions first. CBT for anxiety, which we mentioned before. There's also CBT for depression and CBT for insomnia, which is incredibly effective and a good treatment, no medications involved. And teach people about good sleep hygiene. So make your bedroom comfortable, cut down on your screen time close to bed, cut down on tobacco and caffeine close to bedtime. Prescribe other proven effective medications for anxiety or insomnia. If people have anxiety problems, really the SSRIs, so things like Prozac, Paxil, Zoloft, are actually much better treatments for anxiety than the benzodiazepines over the long term. You can also think about melatonin for sleep. If you do have to use these medications, use them for a specific medical indication for limited periods of time only, really 6 weeks at the most, and collaborate with the patient and caregiver on the idea that this is 6 weeks at the most, and then they're gonna have to stop them, taper them and stop them. And always make sure that patients are aware of the benefits and risks of the benzodiazepine or the Z drug, highlight the risk for misuse, use disorder, withdrawal, and talk to them about signs and symptoms. I'd like to finish this talk with a few thoughts about drug-seeking behavior, because a lot of times in treatment settings, people will say, oh, patients are drug-seeking, they particularly are looking for benzos, in particular, or they're looking for opioids. And this was an interesting quote I came across about drug-seeking behavior. A patient who seeks to continue using a medication because it is helpful is no more demonstrating, quote, drug-seek behavior, unquote, than is a patient who finds eyeglasses helpful in the treatment of myopia or nearsightedness, demonstrating glasses-seeking behavior if deprived of a corrective lens. So this I found in a textbook. I don't know which one of the people wrote it, Robert DuPont, William Green, or Caroline DuPont, but I think it's a really interesting point, is that sometimes we get caught up. We say patients are drug-seeking, but really when people take a medication like a benzodiazepine, that really helps them and it works and they have a problem like anxiety and then they have to come off of it and they feel poorly, they're gonna want to go back to what helped them again. So just want to give that quote. I think it's a good quote, something you can use in the future. And just lastly, on the very last slide, second to last slide, to give some guidance for distinguishing medical from non-medical use, so that drug-seeking behavior from not. So what's the intention? What is the medication being used for? In medical treatment, someone's using it for a diagnosed medical problem. In non-medical treatment, people may be looking to achieve euphoria or manage the effects of other substances. What is the effect on the individual's life? A positive medical effect leads to improvement in functioning. Non-medical leads to a deterioration in functioning. Management, who's managing the medication. In the medical model, it's a collaboration between the prescriber and the individual. In the non-medical, the management is predominantly by the individual. So the individual is saying, I need more, you've got to raise this dose. And it's not being used like it's supposed to. How is it taken? Medically, it's at prescribed doses, at prescribed frequencies, non-medical at higher doses or at greater frequencies. So some things to think about when people are taking medication and you have some questions about how they may be using it. So in summary, benzodiazepines and Z-drugs possess unique pharmacologic properties that contribute to their treatment effectiveness, potential for misuse and adverse effects. Tapering and discontinuing benzodiazepines is usually a long process that is individualized to the individual's needs. Adjunctive therapies for tapering and discontinuing benzodiazepines have not been proven effective, with a few exceptions. So carbamazepine or Tegretol, as I mentioned, melatonin perhaps for sleep, CBT in the short term has been shown to be good. Benzodiazepines and Z-drugs should be reserved until other behavioral and pharmacologic interventions have been exhausted for the medical or psychiatric condition that is being treated. And lastly, this is me, Grace Hennessy. That's my email in case you want to ask me any questions. Really thank you for your time and for listening today. And I'm going to hand it back to Dean.
I want to thank our presenter for today's program. I hope you all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we're meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation, including any suggestions for future topics for Learning Thursdays. Once again, thank you for joining us and keep up the good work.